Oh, great. Thank you, Haley. Welcome everyone to Trauma Screen Time, Part 1. I'm Debra Hallos. I'll be your presenter today. I'm a licensed clinical professional counselor in Montana, and I'm part of the National Native Children's Trauma Center. I'm the interventions manager. The National Native Children's Trauma Center is housed at the University of Montana in Missoula. I work remote and I live in Montana City, Montana, just outside of Helena. And so I'm looking out my window today in my office. It's a beautiful sunny day in this part of Helena. So I'm excited to get going with you all. As we go through, as Haley said, please do drop a comment or a question in chat, and I'll try my best to monitor the chat. And if I were to miss some questions or comments, you can also contact me after the training. I'm happy to do some more visiting and consulting, especially about this topic, which is how to screen for trauma. A little bit before we begin about our center, I'm very proud to be working with the National Native Children's Trauma Center, and also very proud to be partnering with the Tribal Youth Resource Center. So it's our goal to partner along with the Tribal Youth Resource Center to provide training and technical assistance in the field of trauma-informed care or trauma healing care. And we offer training to tribal youth programs and healing to wellness courts as well. We're part of a larger group. We're part of the National Child Traumatic Stress Network funded by SAMHSA. And we're considered a Category 2. And we use current research and tribal best practices to walk alongside child-serving organizations, including tribal justice systems, and child welfare systems, and all child-serving systems to help them be more healing informed. I'd also like to get a shout out to our National Child Advocacy Resource Center. Some of you may be attending today as a result of your connection with our resource center. And we are privileged to be able to work with tribal communities to develop multidisciplinary teams in child advocacy centers. There's a wealth of information that we can share with those centers, and it also is an opportunity to connect with other CACs in tribal communities. Also, before we get started, I'd like to acknowledge that my role is actually funded by two grants, both by the Juvenile Justice and Delinquency Prevention. And any opinions that I express today, findings or recommendations, is solely my own and our centers, and does not necessarily reflect those of the Department of Justice. As I said earlier, the full training will be a two-part series. So I do hope you're able to register for our second part, which will be Monday. But today, what we will cover is why screen for trauma, why is trauma beneficial, and we'll also cover how to develop a screening process for your program. So it's really important to not be prescriptive, but to present the process and things that need to be considered as you develop your own screening process. There will be a fair amount of information covered, but I guess what I'd ask you to do is, as you sit in your program, whatever your role is, to be thinking about, what might work with your program. So it's really about what's going to work for your program. And we know that we have a vast array of folks here from different programs, and a trauma screening process is going to look different in every program. We'll end today with some information about how you can best choose a screening measure for your program. Again, that screening measure is going to look different amongst all our programs and our mission and goals. This information brought to you today is sponsored by the Trauma Screen Time folks. And trauma screen time courses were developed by the Child Health and Development Institute in partnership with the National Child Traumatic Stress Network. You can go to their website, traumascreentime.org, to take an even further dive into the material that I'm covering today. So they offer several courses for free at traumascreentime.org. One is a core course that is pertinent to all child-serving organizations. Another course is designed for schools. Another course for pediatric primary care settings. And there's also trauma screen time training on early childhood. The folks at Trauma Screen Time are also developing a training specific to juvenile justice and child welfare. And I think that is coming very soon. We were told spring of 2025, so it could just be right around the corner. But I'd encourage you to go to this website, especially if you have folks who maybe wanted to join today but weren't able. If you have staff, you do decide that trauma screening is important for your program, it's a great way for your staff members to receive training. Let's talk a little bit about why screen for traumatic stress, for trauma and traumatic stress. Why is it important? And let's take a second to see if that chat box is working. So if you could, please put in the chat why you think it's important for your program to screen for trauma and traumatic stress. Why do you think it might be a good idea? What might you be hoping to find out if you were to screen your program to see which kids have experienced trauma or traumatic stress? Okay, somebody shared that to help find the best resources and services for them. Sure. And it is a best practice, right? SAMHSA has identified screening youth for trauma as a best practice in a trauma-informed or trauma healing approach. It is true as well that it does help us to kind of evaluate our services and make sure that our services are meeting the needs of the youth and families that we work with. Yeah, very good. Meet the client where they're at. But once we know about the experience of the children and families that we work with, it can really inform how we move forward with them in a trauma-informed way. Yeah, these are great responses. So thank you so much for that. And you basically have touched on what we'll be talking about a little bit more. So I think that the good news is that we have a group of people who see the importance of screening for trauma. And I might have to spend just a little bit of time on my soapbox, sharing reasons for why it is such a good idea. Let's talk about what trauma is a little bit. So according to the SAMHSA, which is a Substance Abuse and Mental Health Service Administration, they've identified 3 E's for us to think about when trying to understand trauma. That first E is events. These are difficult or stressful things that can happen to a child. Sometimes out there, like in literature, or if you're listening to other presentations and trainings, These events might be referred to as potentially traumatic events or PTEs. They also include adverse childhood experiences. A lot of us know a lot about ACEs, or sometimes they're just considered adversities. So different words for the same thing, which is basically a really stressful or difficult event that happened to a child that could have some physiological and psychological reactions as a result. So unfortunately, we do know a lot of kids are exposed to these such events. In one study, 61% of children reported experiencing at least one type of direct exposure to violence, crime, or abuse in the last year. 41% experienced multiple types of direct exposure, and 10% experienced 6 or more types of direct exposure. According to the National Child Traumatic Stress Network, of those youth involved in the juvenile justice, 80% report experiencing trauma, with many experiencing multiple chronic and pervasive interpersonal trauma. The second E to consider is experience, right? So that every person and every child is going to interpret that event differently, right? And that's their experience. What might be upsetting for one child and traumatic for one child might not be for the other. And how the individual labels, assigns meaning to, and is disrupted physically and psychologically by an event will contribute to whether or not it is experienced as trauma. So I think we have to be careful as adults working with families and children. We don't want to assume that an event is traumatizing towards a child. And then we also don't want to assume that, oh, hey, maybe that event wasn't that big of a deal because we've seen worse, and so that child shouldn't be traumatized by it. Doesn't care what we think, right? Because it's that subjective experience of the child and how they attach meaning to the event. And lots of things can contribute to how they attach meaning. Depending on their age, with the younger children might feel if there's some violence that they are exposed to, that might really kind of shape their sense of security and safety. Developmental level, like how a child is able to process and think about the event, whether or not the child's already had some trauma or adversity. Other things that contribute to that experience is kind of the cultural understanding, or how a culture or community communicates about the event and attaches meaning to that event, and also the level of support that that child has. Many children can recover from a traumatic experience with the help of loved ones, whereas others might have these effects, which is the third E, that linger for some time. The effects of trauma exposure, we can look at it in two different ways. This is a picture of the iceberg, and of course we see the tip of the iceberg, and there are some observable concerns that we might see amongst kids who've experienced trauma, such as difficulty sleeping, or maybe they're aggressive or cranky, or they appear withdrawn. And those are some concerns that we're able to see. And then down below the surface are these other concerns that maybe we don't know about. Like, potentially they're feeling numb, or they're having intrusive thoughts about what happened, or they're having some shame and guilt and negative thoughts about themselves, or they're avoiding people, places, things that remind them of the trauma. These effects, when they're put together, when kids do have effects as a result of an experience, we call that the traumatic stress reactions. And it's a wide range of emotional, behavioral, and cognitive symptoms associated with exposure to potentially traumatic events. So let's piggyback on everything that you all had mentioned in the chat about why it can be useful to screen for trauma. It certainly can be useful for the children and families that we're working with, and it can also be useful for our organization. So first, let's discuss, oops, I'm going to go back. All right. Let's talk a little bit about how it can be helpful with the children that we're working with. So if a child is experiencing traumatic stress reactions, this distress may get worse, it may persist, could potentially lead to more serious health and social concerns for the child if not addressed, right? So it certainly does make sense to ask the question so that we can start right away to provide referral sources and supports for that child. Avoidance is a really kind of hallmark, a very common effect of experiencing trauma. People don't want to think about or talk about what happened to them. And once we start the process, and we could destigmatize that by just saying, it's commonplace in our program, we talk about trauma because so many people have experienced trauma. We talk about how trauma impacts folks from day to day, and we do this because we know that there are things that we can do to help and that you can heal from these experiences. Right away, when we start the screening process, it's an opportunity for psychoeducation, right? Because we start to inform the children and families about what things could be considered traumatic and what those effects are. Once people learn that some of these troublesome, difficult effects that they're having, whether it's not being able to sleep or having flashbacks, once they understand that that is a normal reaction to abnormal circumstances, it helps to validate them and destigmatize what they're going through. And so that's that, communication piece about traumatic stress reactions that's on this slide. We could really support a child by educating them about what those reactions are. When children and families learn to communicate about these difficult things in a safe environment with people they trust, it increases their sense of safety overall. And it starts the process right away for us to be thinking about planning for those additional supports or treatments. Screening helps your organization. It definitely has the potential to help the program that you're working with. It might help you better understand the behaviors of the children you're working with. For example, you might find that a child who's been acting out and yelling with their peers, actually is coming off of experiencing physical abuse and it's very sensitive to having people get close to him, right? So once we understand that, we can plan our environment in a way that does not re-traumatize the children and families that we work with. And trauma screening done well includes discussion about building resilience, right? So enhancing safety and reducing the likelihood of future exposure. So if you find out that you're working with a child who experienced some community violence, you're there maybe with the caregiver, and you could start thinking about strategies right away that could enhance the safety of that child, what that child could do some action planning. So these things can start right away, helping us to help the people that we work with. And discussion about trauma may also allow you to provide the child and family with strategies for getting immediate support if trauma exposure does occur. Someone had mentioned in the chat that conducting trauma screen is part of a trauma-informed organization. Since I'm referencing that term, I wanted to encourage you all, if you haven't already, to look into some other trauma-informed resources. to help your program kind of be more trauma informed or trauma healing. One resource from SAMHSA is the Trauma Informed Care and Behavioral Health Services. And another SAMHSA helpful guideline is Practical Guide for Implementing a Trauma Informed Approach. Sometimes people might feel, oh, I guess it wouldn't be uncommon or unheard of or even unrealistic for programs to kind of think, gosh, is it hard to do screening? They might feel some reluctance, and I get that. That makes sense. We'll talk a little bit about why some sites are reluctant and see if we can think about what we can do about these obstacles. Sometimes programs are concerned that maybe they don't want to screen because it's just too time consuming, and time is a common concern, right? However, screening measures exist that can usually be completed in fewer than 10 minutes. For many children, particularly those with no trauma, it might even happen in less time. So we can do it fairly quickly. In some cases, especially if a kiddo has experienced quite a bit of trauma, it might take longer. But if we ask these questions right away, we're able to connect them with services right away, which in the long run might save us some time and costs. People wonder, will screening re-traumatize the child or family? And we know that extreme distress is rare. For example, in one national study, less than 1% of children screened for trauma reported being pretty upset or a lot upset by the questions they were asked. And of those who said they were a lot upset or pretty upset, 95% said they would still answer the questions if asked again. And I'm sure it comes as no surprise, the children in that study who said they felt pretty upset or a lot of upset tended to be those who really needed trauma-informed care. When distress does occur, we can minimize it by providing support, right? As ourselves as human beings, or we bring in a supervisor or a crisis counselor to help provide that support. But we also want to consider, it might be hard to ask these questions, but what would happen if we don't screen a child who's experiencing distress? Right? They're going to be experiencing distress if they have trauma reactions, regardless of whether or not we ask. And if we don't ask, they might be sitting and kind of suffering in silence. Another concern folks have is they kind of wonder, hey, am I qualified to screen if I'm not a clinician or a therapist? And to do a screening can be administered by a non-clinical or non-mental health person because screening is different than a diagnostic assessment. And child serving staff without clinical training often, I'm thinking of a pediatric healthcare setting, they often screen for suicide or substance abuse or learning disabilities. So a screening can be done by someone who's not a clinician or a therapist, but we would like to see them get some additional training, and I'll talk about that down the road here. So we just really want to, again, make that distinction. Screening is usually brief. It doesn't diagnose a child or family, but what it does is it indicates that this child needs additional help, additional supports. And if the screening does identify that the child needs additional supports, one thing to do would be to refer them to a mental health professional within your program or outside your program. And that person would then do more interview and a battery of screening and assessments to really make diagnosis and conceptualize the case for mental health treatment. Another reason potentially why people would choose not to to do a trauma screening is they might think, hey, I really know this child already. I know what their trauma history is. But because avoidance, again, is a very strong reaction, we might not know everything, right? We might not know all of the trauma exposure they've had or all of the reactions. For example, a study was completed with child welfare and juvenile justice workers who began screening children they served for trauma exposure and trauma reactions. Many were initially skeptical that they would learn new information because they believed they already knew. However, after the screening, they were asked some questions, and 51% of the folks that did the screening say they actually learned something new about the youth they screened. So there's lots of good reasons, I think, to do a trauma screen. And if I'll just open it up to any questions that you have thus far regarding the importance of doing a trauma screen within your program. And if there are none right now, we'll move over to the next section. And if something were to come up, you could always put that in the chat. So in this section, we're going to spend quite a bit of time going in the ins and outs of how to develop a screening process for your program or organization. And I really want you to be thinking on behalf of your program to answer this question, to kind of start you on that process of developing your own screening. We're going to break down the steps into the who, what, when, where, and how of trauma screening. First, let's start with who is being screened. You can conduct universal screenings, selected cohort screenings, or targeted screenings. And I'll describe each of these along with some pros and cons of each. So a universal screening involves screening all of the children in your program. It has a number of benefits. First, it makes discussion about trauma commonplace. In this program, we screen everybody for trauma because we think it's important. So it can serve to destigmatize. It sends a message that trauma can happen to anyone, and that in your setting, you're committed to treating trauma, to helping children who've experienced trauma. If we screen everybody, it also reduces the risk of biases that may result from gender, ethnicity, family dynamics. And it enables staff to better understand how trauma can contribute to children and their difficulties, everyone in the program. There are some drawbacks of this approach. It can overwhelm a program to screen everybody. And what I mean by that is, if you have 100 kids in your program and you screen all 100 kids and all 100 kids test positive for needing more support, ethically, you need to have those supports in place to meet the needs of all 100 kids. And it can be overwhelming. It can also overwhelm an organization as far as staff members and time it takes to do all of those screenings. So that's one way of screening. Another way is select cohort screening. So that is screening all children of a certain age, grade, or cohort, not based upon identifying concerns. So in the school setting, that might look like, oh, hey, we're going to screen all fifth graders, but not other grades. Or a justice-involved youth might look like we're going to screen the youth in one court district, but not the other. And it has some of the same benefits of a universal screen in that it does destigmatize trauma and provides the same opportunity to talk about trauma and understand a group of kids. if we screen everybody in the cohort, it also reduces potential bias. And it gives us the chance to, when we do a smaller group, to kind of do a practice run, if you will, maybe work out some of the kinks or obstacles in the screening process. So if you start with a select cohort screening, it might set the stage then for doing a universal screening later on. Of course, the drawback is that we're not going to screen everybody, so we're not going to know about everybody. Another way to conduct a screening is what's called a target screening. So this involves screening specific children for trauma exposure and reactions based upon risk factors. For example, targeted screening might involve screening children we know that they've had trauma or we suspect it, or maybe those children who are having behavioral or emotional concerns. A benefit of doing this is we can kind of streamline kids into services right away. So let's say at your program, you're doing a screening and then you're using that screening for group selection into a counseling intervention for trauma. If you already know about the kids who are experiencing difficulty and you screen them first, they could be immediately placed into your group. We wouldn't have to wait then those children who are really struggling for a universal screen, right? So it could be a way of streamlining into services. When we do this, a drawback might be that we are introducing a bias. It's sometimes difficult to know when we are acting on a bias of either sex, ethnicity, or family dynamics. And of course, we're just screening a smaller amount. But all of these types of screening groups have merit, and you'd have to think about which one fits your program best. Well, let's talk a little bit about the who. So the who will be answering the screening questions. And we can think about all of these possibilities. Now, most screening instruments have child and caregiver components. And often it's useful to screen both the child and parent because then you're getting both perspectives. But depending on your setting, you may only have access to only the child, or you may only have access to only the parent or caregiver. We could still do the screenings, and there's benefits and drawbacks of that. If you have access to both child and caregiver in your program, the next question would be, now, do I screen the child and caregiver together, or do I screen them separately? Let's just talk a little bit more about all of these options. If you only have access to a child, it's still, and that's all, you just have access to the child, it's still important to screen that child, and there are some benefits. It would take less time. The children seem to know a lot about their trauma exposure and effects, and they might be more likely to disclose information with you if they know that their caregiver isn't going to find out. Some drawbacks is that you miss the caregiver's insight, and that it is a little bit harder to screen small children because what caregivers can really help with are those missing pieces that kids may have, like maybe they don't remember everything about the trauma, or there's some developmental delays, and so the caregiver can fill in the blanks. And that kind of leads us exactly to why it is important to screen a caregiver, even if you only have access to the caregiver and not the child. They might know additional information about the child's trauma, and they might also be willing to share information kind of about their family situation, provide a background about the trauma that maybe they wouldn't be willing to provide if the child was present. Sometimes caregivers don't know that much about their child's experience. Sometimes they don't want to share because they might be the one causing harm, unfortunately, or they might be too embarrassed, or they might fear that you would need to report it to child services. Oh, so, maybe for your program, a good way of handling this would be to screen both the child and caregiver and do it together in the same room. Um, there are some benefits to having the caregiver and child in the same room, and it really kind of depends on that caregiver relationship. So if it's a loving relationship, the caregiver might be able to provide that real-time support to the child. The child might feel more secure and safe with their caregiver in the room with them. It'd be easier for the facilitator of the screening to talk about next steps when they're both together. But the drawbacks, again, with both the child and caregiver, if they're being asked questions in the same room, they might not be as forthcoming with their answers. We hope this doesn't happen, but sometimes the caregivers may minimize or deny or disbelieve the disclosure by the youth. So given that information, hey, maybe screening the child and caregiver separately might work in your program. It's interesting that research has shown that multiple reporters often provide a more complete understanding of the child. So if you have a caregiver taking a screen with you in one room, and then you interview or screen the child next, you get a more complete picture because you're having those two perspectives. But even if you were to screen them separately, please remember that you'd have to bring them back together to share the results. Because if I didn't say before, whenever we screen children and family, it's paramount that we discuss the results with them. There are some drawbacks of screening the child and caregiver separately, and that is it takes more time and it could make things a little bit more complicated when we do stand back to try to implement or to try to interpret the results. Next, you want to be thinking about who in your program, what staff member should conduct the screening. And you might want to ask yourself these questions about the best person to do the screening. It might be that staff member who already knows the child and family. You'd want the staff member to have some general behavioral health knowledge. Now, they don't have to be mental health people or clinicians, but it's great to have that general health knowledge. You would want your staff members to have some understanding of what trauma and trauma experience is. You might want to have them have some understanding of what trauma-informed care looks like so that they understand trauma and possible impacts on children and families. And then they really should they're going to need time to not only conduct the screen, but discuss it with families, make referrals, and support the family with next steps. You may consider really providing opportunities for your staff members to get training in how to conduct a trauma screen. And for sure, it would be beneficial to have at least one staff member there as a supervisor, or maybe it's a consulting mental health provider, where staff can turn to that person when they have questions about screening. And also a trauma healing approach really does take care of their staff members. It is a big ask. It could be a big ask to require staff members to ask about trauma experiences. It can be heavy. And we know that those of us in the helping profession are prone to secondary traumatic stress. So think about having some supports in place in your program for those staff members who are actually conducting the screens. A place to debrief, a place to connect and to ask questions, maybe an extra mental health day off. Okay. So we're thanks for hanging in there with me and going through these questions. The next one is the what of trauma screen. And what we'll be talking about is what resources you may need and also what services are available. So when conducting a screening, you just need to think about, will there be some administrative cost or some administrative extra work? If you choose to do a paper format, it might look like making all these copies. It might look like setting up scheduling, right? Do you have access to screen children? Like, how do you develop a safe place, a confidential area where children can go through the screening process? And just to hit back on that point I made earlier, having access to training, supervision, coaching, and consultation. Those are some resources that you might need to have in place before your screening process. We want to also make sure that you have services available before you start a screening process. So really doing an inventory about what are the supports within your program, what are best practices that you utilize to support children who've experienced trauma, right? Maybe it's utilizing your relationship. Maybe it's minimizing those things that could be re-traumatizing to children in that environment. But it also needs to be a referral to a higher level of care. So if you have mental health professionals in your program, having that referral ready to go, or maybe it's some groups that your children can attend. Maybe you want to think about starting a clinical group for kids in your program who've experienced trauma. Other times, if it's not available in your program, I really have to have a list of those folks in the community or telehealth who can offer evidence-based trauma-focused treatments. So let's visit just for a few minutes about what evidence-based trauma-focused treatments look like. So there are specific types of talk therapy that have been shown to be effective for children who've experienced trauma. If you go to the National Child Traumatic Stress Network.org, you'll find a long list of these type of treatments. And they're evidence-based because research has shown that they are effective in reducing those reactions for kids who've experienced trauma. Many of them have shown to be effective amongst many different children from different ethnic groups, gender, and ages. But it does help to do a little bit of research, even if you're not the one who's going to be providing evidence-based trauma-focused treatments. It makes sense to ask questions of those mental health providers in your community. How is it that you work with children and families who've experienced trauma? Are you trained or certified in evidence-based trauma-focused practices? And we want to also start to establish, if it's services not within your program, but outside your program, getting to know those people a little bit so that you're in a better place to make a warm handoff, if you will. Walking the child into their first appointment with that mental health professional, saying something that you know about that professional. So that, again, to reiterate, but it's just so important that ethically, before we conduct any type of trauma screen, we need to make sure that we have supports at a referral source in place so children who test high will receive the services that they need. Okay, so next we'll cover when to screen kids for trauma. You could screen them earlier when they enter your program, or you might decide to screen them a little bit later. If you screen them earlier, again reinforces that trauma is an important consideration at our program. We normalize the discussion of trauma, and then it results in an earlier match of needs and services. If we screen later in the program, the benefits might look like, hey, it gives us more time to get to know that child and develop a relationship and trust. So they might share more information with us. It give us more time to learn about the child and family to inform the screening and service needs. You might find too that there are just practical times within your program to incorporate screening. So maybe you do it with a other battery of screenings that you typically do, right? You might ask yourself, is there a good reason to do trauma screening separately? And you want to make sure that you're able, just kind of within the course of your program, to find a time to screen that really allows, like you're going to do a trauma screen, and then that a child naturally leaves your program within 2 weeks. You want to make sure you have time to do the screen with the child, and then make sure that they are connected up with the resources that they need. So really to kind of solidify when it would make sense for your program to do a trauma screen, consider asking these questions. When are the results, depending, given what we know about your program and organization and the programming and things that kids do as part of belonging to your organization, when might the results be most likely to be useful? And when in the child and family's involvement are they likely to be most comfortable with the benefit of trauma screen? Okay, we're going right through all of these questions. You guys are doing great hanging in there with me. We'll just like briefly talk about where it makes sense to do a trauma screen. And you can do it in person, or you could do it virtually. Some trauma screens are actually designed to where they could be done electronically. Certainly in person, it gives you the opportunity to read the child and family and to pick up on nonverbal cues, and also provide them support in real time and discuss next steps. It's easier to share resources, but not all families have the ability to come in. They might have some obstacles. And if that's the case, you could also do a screening with a child virtually, right? You would just need to be careful that they had the appropriate technology. It might be more difficult to build rapport. And it also might make warm handoffs to behavioral health provider a little bit difficult. And you don't have control of the environment either. You're not sure, if they're going to be in a safe and secure place where you can maintain their confidentiality. So the last question is how? How do you conduct your screening? If you join my session on Monday, we'll get into a little bit more of the relationship dynamic and some helpful tips for the implementer working with a child or family. But the how today is to think about whether you want to interview the child and ask the questions, or whether or not you have them self-report. Some screenings are designed for interview, others are designed for self-report, and yet others can be done either way. Again, with very similar to the in-person experience, if you're interviewing a child, it does give you that kind of seamless opportunity to get child assent, caregiver assent if the caregiver's in the room. You can observe nonverbal cues, and you're there to provide support and answer any questions. It does take a little bit more time to sit down and interview students, and so you might have you might be limited by staff capacity. And also it's for some kids, especially older kids, if you're asking them those questions, it might be perceived as a lack of privacy. They may be better suited for self-report. And self-report is beneficial, especially if you're screening a large number of students, right? Or where that, hey, that's just commonplace. Like when we do assessments in our program, everybody just fills out the information on their own. It is a little bit more appropriate for older children who have some reading ability and can sit and think and work independently. Some of the benefits of that self-report is that it does offer more privacy and require less time. More efficient when we're screening large numbers of children, and some people are just more comfortable doing it that way. But if some drawbacks might be that they might not have the great adequate reading ability, they might not understand the questions. And if they're upset, it would be harder to provide them that real-time support. And, so earlier, when I was kind of talking about what some of the concerns are for not doing a screening, we don't want to present as if difficult situations won't arise when you are conducting a screening. We know they will. Here are some challenging situations that might arise during the screening process, and we'd like to talk a little bit about that. The first one to talk about is that mandated reporting. Child serving organizations and staff are required by law to report cases of suspected child abuse in accordance with the Federal Child Abuse Prevention and Treatment Act, or CAPTA. Different states have different mandating reporting laws, and so it's very important to understand the reporting laws of your state. It's also very important to understand the process within your program for how things are reported. And not all trauma exposure will require a reported case of suspected child abuse, but some of them will. And so you have to have that understanding of mandated reporting, including policies that your program might have for explaining to children and families that limits to confidentiality, that you are required by law to report suspected incidences of child abuse, and you're required to do that because we need to make sure that the kids that you serve are safe. Another concern might regard suicide, self-injury, or harm to others. We do know that when kids are exposed to trauma, it does increase their risk of suicide, and that the two are connected. Now, most trauma screening measures do not ask about suicide, self-injury, or intent to harm others, but it still could come up. A child or caregiver may volunteer this information, or you might be having the child and caregiver taking other screenings that do ask about suicide, self-harm, or harm to others. When this comes up, we just really need to work to make sure that we're maintaining a sense of safety for that child. So we want to remain with the child and family until a crisis clinician or supervisor can assess the situation. You might say something like, hey, I'm concerned about some of the things you shared today, and I'd like to have you talk with a clinician before you leave to make sure that you're supported. Also, if you have training in crisis intervention or suicide prevention, like assist or question, persuade, refer, or safe talk, you could very well kind of be in that position to offer support and intervention right there, and then and talk about that suicidal ideation. Again, most organizations have policies and practices related to the risk of suicide, harm or threats of harm to others, including immediate crisis support. So staff at organizations screening for trauma should verify the existence of such policies. If you don't have those policies and practices in place for responding to suicide, self-injury, or harm to others, it's a good time to start, right? You should have those practices in place before you conduct a trauma screen. Sometimes extreme distress does happen. If you remember just a few minutes ago, I shared that it doesn't happen that often. One study said it only happens in 1% of respondents, but it certainly could happen. And if it does, we wouldn't be horribly surprised because it could just very well be, again, that normal reaction to abnormal circumstances, right? And so I think we validate that experience and we provide some understanding as to, we understand why you would be feeling this way. But we might have to follow up by asking a counselor or therapist experienced with crisis management to come in. And when there is extreme distress, the staff member who's implementing the trauma screen will also need some support. And I talked about that earlier, just having supports in place for those people who are asking the difficult questions and absorbing the difficult responses. So I know we just went over a lot of information about the who, what, when, where, how. To start that process of, or to start designing a screening process with your program. And I'm wondering if you have any questions. Okay. And let's see, Jeff, you had written a question in the question and answer box, and it's just you have a large after school program and wouldn't have time to screen once the program started. Might an option be to send it home with the applicant and then follow up with the mental health clinician who's on staff? I think there might be, some pros and drawbacks to that as well. One drawback might be that not being present or being in the same area as the child completing this trauma screen, you might not know if they have some distress. You might take a while then to follow up with them if they were to take it home. And the quicker that we follow up, the better. I could see that there might be some drawbacks, but yes, a potential benefit would be that it would save time. Let's see if there's any other questions in the chat. There is a screening tool that I can share, and I'm going to do that next. Let's see. The difference between a screening and assessment is another question in the chat. So screening measures, tools are typically brief. They ask about symptoms and experiences, but they're not meant to diagnose. What they're meant to do is indicate that that child needs more services. One service that would make sense would be an assessment. An assessment is done by a clinical mental health person who can ask questions, provide a battery of assessment, and then be in the position to diagnose. So a screen is to identify concerns, and an assessment is to diagnose issues and conceptualize treatment. Let's see. And then is there an disadvantage to screening more than once? There are advantages to screening more than once. So it could really inform whether or not some of the services that you have for students is helping them with their trauma exposure and trauma symptoms. And it also can help, I guess, feed your program in understanding whether or not the screening process is helpful. And I'm going to talk a little bit more at length about that particular topic on Monday, if you're able to join Monday. And then I wanted to address another question in the chat before we move on. From Ashley, and that's that trauma screening seems to be focused on bad things that have happened to us. How do we counter these feelings of my life has been so bad? So I guess another way to look at it might be that difficult things happen to a lot of people. In fact, they happen to so many people that we have a screener to ask questions about it. Because we also know when difficult things happened, we can find ways to heal and to overcome. Once we know and we share with others the difficult things in our lives, it often helps us to feel better right away. And then it also gives us the opportunity to find more supports so that we can heal from those difficult things. So that's how I would address that. It's true, trauma screening does ask about traumatic events, but it also provides a sense of hope that difficult things happen. But hey, our program, we have things in place to help. And also, I know people outside of our program that could help even more. So I kind of see a trauma screenings as also instilling some hope. And there's another question about a pre-post screening, and that can be helpful. It's a little bit more helpful to do that in a clinical setting. Do a pre and post assessment so that the person implementing the clinical intervention can determine if symptoms have gone down as a result of the intervention. You could potentially do a pre and post screen for your program as well, which is you would give the exact same screener that you did when they entered the program. You'd give the exact one post as they exit to see if there was a difference in or reactions, if reactions had decreased. Those are some great questions, and I kind of like to move on. Thank you so much for asking those questions. I'm going to guess that one reason why a lot of folks joined today is because they would like to learn a little bit more about actual screening measurements. And so at this point, let's talk about those screening measurements. And there's a lot to consider because there are so many screening measures. There's a lot to consider. And I know, Andy, if you wouldn't mind, if you have the opportunity, if you could drop that first resource in the chat for folks. The Trauma Screen Time has developed resources to help us figure this all out. And this is some things that we need to consider when identifying a screening measure. We'll get that in the chat, and then these documents will also be sent to you after my presentation today. What's very important to think about when you're screening for trauma is that you have to screen for both potentially traumatic events and reactions. Okay, go back to those E's that I talked about at the start. We want to know what events children have experienced. But we also want to know, based upon these difficult things that happen to you, how are you doing today? How is it impacting you today? So it's only a complete screening if we ask for both events and effects. Now, this is important because some screening measures only ask kids about what events they've experienced. It's okay to give that screening measure, but then you also have to give a screening measure that is asking about events. Yet there are some screening measures that ask about both. One I'm going to share with you just a little bit down the road. When you're selecting a screening measure, go for brief, right? We're not doing an assessment. So we want to find a screening measure that's 10 or fewer items. Children and families can complete those items in just a few minutes. Be careful about costs. A lot of screening measures are free. Others cost, right? And so you need to make sure that you have the funding available to supply everybody you want to screen with those measures. It's really important to also ask, hey, is there some evidence behind this measure, right? We want to make sure it's been tested so that we know the measure that we're giving a child can differentiate between, can point out children who have experienced traumatic stress reactions versus children who are not. So we want it to have some validity and a clear cutoff score. That validity tells us that, yes, this screening has proven to be correct in answering the right questions. And if we do it over and over again, we're going to get a similar result. The screening measure should also have a clear cutoff score. That is, hey, if your score is 3 or higher, this is an indication that the child would need more supports. Screening measures are validated for use with different populations and in different languages. Okay, so we want to do a little bit of research on our screening measure. Not only has it been evaluated and proven to be effective, but on what populations has it been proven to be effective? Has it been used with children of different ethnicity, sexes, and age groups? Some screening measures, most of them will tell you which age groups it's appropriate for. Most of them will also tell you whether or not there's a child report and a caregiver report. And does the screening measure add more information, right? Is it something that is important for us to learn? Right? Can it be added? Can these questions be added to other screening measures? Because we do know if we incorporate a trauma screening measure with other mental health type of questions, then we're going to get a more informed and complete picture of the child and family's needs. Another thing to consider is, can it be done electronically? So if you have a data system, an electronic data system, or it's an electronic client or patient chart or file, you might want to look into those screenings that can be done electronically. Sometimes when that happens, there's additional costs. This is a very important resource as well. And Andy, if you have the opportunity, could you please drop this in chat? This is a very extensive summary of trauma and adversity screening measures. So if you have this document, you're able to kind of look through all the measures that are out there to help you kind of determine whether or not it's a fit. So it describes age groups, and it describes whether or not it's child and caregiver, whether or not it's interview or self-report. So it's a very valuable resource to have that kind of answers like all the questions and concerns, things to consider that I just talked about. Here are some resources, here are some screening measures that we'd want you to take a look at. These are also in that guide. One is the Child Trauma Screen, or CTS. There are currently 3 versions of this CTS available: a child report for ages 6 to 17, a caregiver report for ages 6 to 17, and a caregiver report for young ones, 3 to 6. Sometimes it's hard to find a screening measure for those early childhood folks. And Andy, if you get the chance, you could also pop this in the chat. And then also please rest assured that those of you that are registered will be sending the PowerPoint and these documents for you to look at closer. So we'll be sending the child traumatic stress screening measures to you, so you could take a look at that. Another one we'll be sending was developed by the University of Minnesota, and it's the traumatic stress screen for children and adolescents, or TSSCA. This measure is free, and it contains just 6 total items. 1 assesses events, and 5 questions that assess reaction. And this is another one that if Andy has a chance, I'll ask her to pop into the chat. Thank you so much, Andy. Okay, so that will end the information that I have to share with you in this first part series. And I'm hoping that maybe you have a chance to look at some of the documents that are being put in chat. And I'd also like to, we have, some time, we still have about 10 minutes. So are there any other questions that I wasn't able to get to? Burning comments, concerns, anything that you'd like to share? This would be a great time for us to do that now. So feel free to put any of that in the chat. Oh, so if there are not other questions, I'd just like to put a little plug in for the next webinar OLE that will be offered